So my name is Josh Niekamp. I'm one of the sixth-year Hem/Onc fellows. I think I've probably been able to meet a lot of you guys who are listening or who will be listening. I've been here for residency and for fellowship. So I've been here at UC for a while. And I will be talking to you guys today about plasma cell dyscrasias. I think the first thing that I really want you guys to know is I hope you guys are all really appreciating the title slide to my presentation. Microsoft Office has started giving recommendations on like title slides, I guess, based off of whatever you title your lecture as. And I don't know why it recommended this as like the best title slide for a lecture on plasma cell dyscrasias, but they did. So I think it's pretty sweet, even though blowing wheat field, I don't think has anything to do with plasma cell dyscrasias, but I hope you guys are pretty impressed by it. So talking about plasma cell dyscrasias, I guess the first thing is that technically plasma cell dyscrasia is an antiquated term, but we still use it a lot. And I think it's mostly just because it's really fun to say the word dyscrasia. And the other thing is I don't even remember what the new term is for it. So I think it's something like plasma cell disorder or plasma cell proliferative disease. But in any case, we still say plasma cell dyscrasias a lot. And basically this is just kind of a catch-all term for any disease that's caused really directly or indirectly by plasma cells or even near plasma cells. And even though when we talk about plasma cell dyscrasias, we're usually referring to multiple myeloma, the reality is there's probably, at least in the double digits, maybe even in the triple digits, number of plasma cell disorders that we can deal with. So really the focus of this lecture is going to be talking about multiple myeloma, which is sort of the greatest of, or the most tested of the plasma cell dyscrasias. But sort of in that same vein, I'll talk some about MGUS and smoldering myeloma, and then deal with a couple of the other plasma cell disorders or dyscrasias just that you might have heard of or might be tested about or might get pimped on. So kind of first things first, just to remind you guys what a plasma cell is. So a plasma cell, you can see from the slide, matures from a B cell. And so it kind of goes through this long lineage that starts in the bone marrow compartment and moves, to pro-B cell, pre-B cell, goes into the peripheral compartments and gets into the bloodstream and the lymph nodes. And then ultimately, plasma cell is kind of the final step of maturation. And at that point, the plasma cells really go back to the bone marrow. You can still sometimes see a few plasma cells sometimes circulating in the blood, and sometimes you can pick up plasma cells in the lymph nodes, but by and large, plasma cells are supposed to be living inside the bone marrow. The second thing, it's a little bit tough to see from this slide because it's a little bit blurry, but if you look at kind of the different CD markers, so CD19 and 20 and 38 being the main ones, the main thing that I would want you to pick out is that most B cells and most things in the B cell lineage are positive for CD20. And you guys have maybe heard of like rituximab or Rituxan. That's a CD20 monoclonal antibody that we use in treatment of a lot of lymphomas. But as the plasma cell, as it matures and goes, to that final step, it actually loses CD20, but it is very strongly positive for CD38. So if you kind of follow along and squint and try to see the pluses and minuses on the different CD markers, you'll see kind of gradually, as it matures, it tends to pick up more CD38 and tends to lose CD20. And that'll be kind of important a little bit later in our lecture when we talk about some of the other plasma cell disorders. So this is a picture, just so you can see a little bit of the differences. The picture on your left-hand side, kind of the cell that's mostly nucleus, that is a lymphocyte. And you can see a lymphocyte, kind of the key feature of that is that it's almost all nucleus. There's a very thin rim of cytoplasm, and it's about the same size as a red blood cell. On the other side, the picture with a little arrow pointing on it, that's a plasma cell. And you can see a plasma cell has a lot more cytoplasm. It still has a nucleus that's about the same size, but there's a lot more cytoplasm. If you kind of squint and you look at the edge of the nucleus, you can see there's kind of a clear spot on the cytoplasm, sort of a more clear spot next to the nucleus. And that's called the Hoff. And that's really basically just like the cell's Golgi apparatus that's full of antibodies. So remember, a plasma cell, as it matures, its job is to mostly make antibodies. And so you can kind of see that as you look at it under the microscope. There's a lot more cytoplasm because there's a lot more going on inside a plasma cell. And then this cleared area is a bunch of basically antibodies in storage. So this is just a picture to show you, though, that it's still kind of tough to figure out what different cells are. Scott, are you able to see my cursor as I point, or do I need to like use the pointer on PowerPoint? Can you see my cursor and see what cells I'm pointing to? Bummer. Well, let me try this. How about now? Can you see the circle I'm making? I bet you can. So the cell I circled is, that is a monocyte. So it has, in some ways, it has some similar features to a plasma cell in that it's a big purple nucleus and a lot of cytoplasm, but a monocyte tends to have a bigger nucleus. It's kind of an irregular nucleus compared to the plasma cell, which is down here. And it also has these very clear areas that are basically completely see-through. Those are lysosomes, which is different from the Hoff body, which is sort of a more or less clear than these here, which are the lysosomes. So this next set of cells, these are also monocytes, although you can see they look fairly different from the other cells. This cell here, there we go. This cell here is also a lymphocyte. It looks fairly different from the lymphocyte on the last slide. Let me see if I can go back to it. You can see, oh well, I'll just keep going. So you can see there's definitely more cytoplasm, but this is actually an atypical lymphocyte, kind of like what you would see in somebody with an EBV infection or another viral infection. These cells here, which again have some features similar to a lymphocyte in that they're mostly nucleus and have very little cytoplasm. These are actually lymphoblasts. You can tell they're different from a lymphocyte, that they're a bit bigger than the lymphocyte is, and also they have sort of these more clear spots inside the nucleus. Those are the nucleosomes, which you really only see in blasts. So we kind of say that they look like eyeballs, and so if you're looking at a cell and it's looking back at you, it's always a bad sign, and that's a sign that it's blasts. This cell, in this frame, you guys are probably very astute to see that even though it is mostly nucleus and has a very thin rim of cytoplasm, it's too big to be a lymphocyte or a plasma cell, and it has these inside, which are Auer rods. So that's an APL cell. And then again, this last one that I already circled is another picture of the plasma cell. So I guess long story short, it takes a lot of training to figure out the differences between, all of the cells. The first picture I showed you, you can kind of pick up the basic difference between a lymphocyte and a plasma cell, but once you're looking at a lot of cells under the microscope, it's kind of confusing what is what and which is which. So just so you guys know, I think that's mainly why my paycheck makes like $37 more than your guys does, just because, you look at these cells and you don't know what they are, whereas I would look at these cells and I also don't know what they are, but I know where the hematopathology office is, and so I can get an answer a lot quicker. So I think that's kind of one of the lessons I want you to learn today, is that as you progress through residency and then maybe fellowship, it's not really that you learn more. You're actually equally as dumb as you always were, but you get a lot better at figuring out who to ask for answers. Don't tell Dr. Warm I said that. All right, so last kind of intro slide, just to remind you guys, when plasma cells are making antibodies, there's all these different classes of antibodies that can be made, and you guys already know this. But just to remind you, there's IgG, IgA, IgD, IgE, and then IgM. IgG is a monomer, whereas IgA is a dimer and IgM is a tetramer. And the fact that IgM is a tetramer is also important to remember when we start talking some about Waldenstroms. So now just really getting into sort of the meat of our talk. Multiple myeloma, that's kind of the most common plasma cell dyscrasia probably that you'll see and be tested on. And just a little bit of an overview on it so you guys know a little bit what we're talking about with myeloma. So again, it's clonal plasma cells. It's a disease we see primarily in older adults. It's really kind of an indolent disease, and most people diagnosed with myeloma will live 7, 8, 9 years. So it's something that we have some pretty good treatments for. Kind of the ideal thought in terms of treatment is that our goal would be to give somebody an autologous, meaning their own, an autologous stem cell transplant as kind of the definitive treatment for their disease. So the ideal scenario would be you give somebody induction chemotherapy, followed by a consolidation autologous stem cell transplant, followed by some maintenance chemotherapy, which would usually just be a single drug. The reality is, though, some people get induction chemo, followed by an autologous transplant, followed by maintenance chemo, and then they relapse, and then they get more chemo, and then they relapse, and they get more chemo. There's also a lot of people who really never get a transplant. They just go from chemo to relapse to next chemo to next relapse. And many people will end up getting, 4, 5, 6 lines of treatment for multiple myeloma, which is part of why the life expectancy is now so long. So again, it's typically a slower growing disease. Kind of the classical progression is that somebody will start with MGUS, so they'll have a monoclonal gammopathy. As it picks up more and more mutations in that monoclonal cell, it will become sort of gradually more aggressive, and so it will continue to grow and become a smoldering myeloma and continue to grow and gather mutations until it becomes symptomatic. And it's really characterized, even though the problem is the plasma cell, we usually pick it up not from first measuring plasma cells in the bone marrow. We usually pick it up by seeing this monoclonal protein that we measure in the serum. So most commonly, the monoclonal protein is IgG. There definitely are a fair number of IgM and IgA multiple myelomas. There's very few IgD multiple myelomas, but they do exist, and I've seen a couple as a fellow. IgE myelomas, though, even though they exist, they're incredibly rare. I think there's maybe around 50, I think less than 100 reported cases. So if you guys ever see an IgE myeloma, make sure you write it up, because it would still be worthy of a case report. Now, that being said, not all myelomas make immunoglobulins, or at least make whole immunoglobulins. So there is such a thing as light chain myeloma, in which the plasma cell is really only making kappa or lambda light chains. If I go back a couple slides, just to remind you guys, looking at this IgG here, this part right here, what you see in pink, that's the light chain. So remember, there's 2 light chains, and then there's 2 heavy chains. That would be kind of the greenish blue area that combine in order to make an immunoglobulin. So there is light chain myeloma that is just making the light chains instead of the whole immunoglobulin. And then also some myelomas make very little or even make no monoclonal protein. And those are actually kind of hard to diagnose and hard to follow, because we can't really measure anything in the serum. We can't measure any immunoglobulin or light chains. The only way we know about it and know how to follow them is by finding out how many plasma cells they have in the bone marrow. Now, again, all of that being said, some multiple myelomas present differently from a kind of classic or typical myeloma. You can also have a plasmacytoma, which is basically a tumor just composed of plasma cells. You can also have a really aggressive plasma cell leukemia, in which basically the bone marrow is just so full of plasma cells that they're spilling out, and you can measure them in the periphery. So there is a wide range of how myeloma can present, but by and large, kind of classically, we think of it as this progression, MGUS to smoldering myeloma to symptomatic myeloma. And we typically think of it as expressing a monoclonal protein, which is most commonly IgG. Now, kind of talking about this progression though, talk a little bit about MGUS and then a little bit about smoldering myeloma and then the actual active myeloma. So MGUS stands for monoclonal gammopathy of undetermined significance. That term was coined by the guy you see a picture of, Dr. Kyle from Mayo. And even now, probably, most of the multiple myeloma papers that you would read have Dr. Kyle's name on them somewhere as being involved. So he's done a lot of work in myeloma. But in any case, defining MGUS, actually getting to the stuff that you guys might be tested on. So MGUS would be defined as having a measurable M spike that is less than 3 grams per deciliter. So remember that number, 3. And also involves having less than 10% plasma cells in the bone marrow. The third thing, or third group of things, is that you can have no end organ damage. And when we're talking about organ damage in multiple myeloma, we often will discuss the CRAB criteria. So CRAB is an acronym. You can see what each of the things stand for. So you can C is for hypercalcemia, R is for renal dysfunction, A is for anemia, and then B is for having bone lesions that specifically are lytic bone lesions, not blastic bone lesions. So things like prostate cancer will tend to cause more blastic bone lesions, but multiple myeloma, hypothetically at least, should only cause a lytic bone lesion. So again, MGUS is a monoclonal gammopathy, but it doesn't meet criteria for myeloma and it doesn't cause any symptoms. It's typically found incidentally in workup for another disorder. And this is just a study that was done basically showing why did people, get diagnosed with MGUS. And so oftentimes it's done in workup for anemia, but can also be done for these other things like having bone pain, having neuropathy. And most of the time, MGUS is diagnosed by one of you guys in medicine and not by a hematologist. So about 80% of the MGUS diagnoses are made by usually the primary care physician. So typically, I remember getting asked the question a couple of times in my residency about what's the rate of progression to myeloma from MGUS. So we use this, the number that is always the correct answer to that is that there's a 10% risk of progression over 10 years. The fact is we can actually refine this a lot more. And so once you guys know this, you'll even be smarter than your attendings. So Mayo Clinic has developed a risk stratification tool for MGUS, and you can come up with 3 different risk factors. So one is 1 point if they have an M protein that's above 1.5 grams per deciliter. They get a 2nd point if it's a non-IgG MGUS, so if it's IgA or IgM. And then also measuring the free light chain ratio. So measuring those light chains, kappa and lambda. And if you have a predominance of either kappa or lambda, you'll have an abnormal ratio of those, which can also be a sign that you have a abnormal monoclonal process. So as you break it down, if you have none of the risk factors, your risk of progression over 20 years is actually only 5%. If you have one of the risk factors, the risk of progression would be about 20% over 20 years. So that's kind of the standard answer, lumping all MGUSs together. Then you can see as you develop more of the risk factors, the risk of progression goes up higher and higher. So for me, I probably need to memorize those different risk factors. I don't know that you guys necessarily need to, but I think just be aware that it exists, and I just took a screenshot. You can go to, MedCalc or Google, wherever, and look up this prognostic system. And when you just punch in the 3 numbers, it'll give you what the risk of progression is. So I think it's a fairly useful tool because based off of how, how many risk factors somebody has in MGUS, that kind of helps decide how closely you need to follow them. So everybody has their own ideas of how closely they need to follow MGUS. And if, if you look up 4 different societies, you'll get 4 different answers, but this is one that just kind of fairly makes sense. Also from folks at the Mayo Clinic. They recommend if you diagnose someone with MGUS, you should follow up everybody in 6 months and decide if the M spike is stable or if it's progressing. If it's progressing, then you might need to work them up further, but if it's stable, then you can use this risk stratification tool. And they actually recommend that if they're low risk, if they don't have any of the risk factors, that you may not even need to ever check them again. The reality is most of these patients get referred to hem-onc, and generally we follow people once a year unless they're very elderly and we think they're going to imminently die of something else within the next couple of years. We'll usually follow them once a year and just get a repeat SPEP and serum free light chains. So now moving on from MGUS, the natural progression again would be that MGUS eventually tips over to myeloma. So smoldering myeloma would be defined as having an M spike that's equal to or greater to 3 grams per deciliter and having at least 10% plasma cells in the bone marrow. But the thing that makes it smoldering is that there's no CRAB criteria. So again, I know it's not very easy for you guys to answer questions just over the WebEx meeting, but just to remind you guys, probably the CRAB criteria are things you should commit to memory. So remember the C is a high calcium, it's kind of defined as above 11. R is for renal dysfunction, defined as a creatinine of 2 or higher. A is for anemia, defined as a hemoglobin of 10 or less. And then B is for lytic bone lesions. Again, it's lytic, not blastic bone lesions. So just a quick aside, the question that I had is, you can see, the criteria says having an M spike above 3 and plasma cells above 10%. But what do you do if you have one but not both of these things? So for instance, what if the M spike is above 3, but you do a bone marrow biopsy and they have less than 10% plasma cells? Or the reverse, what if they have an M spike that's less than 3, but they have more than 10% plasma cells? So this would be a fairly rare scenario, but really the second of these is more likely, that you would have a lower M spike than you would of the plasma cells. So the reality is that it's really the plasma cells that we care about in terms of diagnosing myeloma. The M spike is really just kind of a surrogate marker for the expected number of plasma cells. And this magic number of 3 came about because it's very, very sensitive for having at least 10% plasma cells in the bone marrow. So it would be very rare to have an M spike of 3 or higher and not have 10% plasma cells. Technically speaking, though, I believe that either of those things would qualify a patient as having myeloma. So technically speaking, both of these scenarios would count as myeloma. So you only need, going back, I think to the previous slide, you only need the M spike or the plasma cell criteria. You don't have to have them both, although you almost always will have them both. So now moving from smoldering myeloma to multiple myeloma, it's really the same, it's just now you have symptoms. So again, the M spike is greater than or equal to 3, you have greater than or equal to 10% plasma cells in the bone marrow from doing a bone marrow biopsy, plus you have one of these CRAB criteria. So they are hypercalcemic, have renal dysfunction, they've become anemic, or they have lytic bone lesions. Now, I don't think you'll need to know the details on this slide. I think really you'll just need to know the details on this one. But there was a few years ago, in 2014, there was a revision so that now there's a couple other scenarios where people qualify as having truly multiple myeloma that needs treatment, even if they don't have any symptoms from it, no end organ damage. So those criteria is that if you have greater than 60% plasma cells, you consider it active myeloma. If you have a very high or very low kappa lambda ratio, meaning you have a very high predominance of either the kappa or lambda light chains, that's no longer smoldering myeloma. And then there's also kind of a weird imaging criteria. So they decided that if you see any lytic lesions on an X-ray or a CAT scan or a PET scan, that counts as a lytic lesion to make active myeloma. But since MRIs are much more sensitive and can see much smaller lesions, they say that an MRI you would have to have 2 lesions and not just one on an MRI. So again, I don't think you need to know these things. I think you should just focus on committing this slide to memory and knowing that cutoff of 3 grams, 10% plasma cells, and then know the CRAB criteria. So another quick aside is, what if somebody has the CRAB criteria, but they don't have an M spike above 3, or they have less than 10% plasma cells? The reality is you would still call that multiple myeloma if you're fairly certain that the end organ damage is related to the plasma cells and not from something else. So for instance, if you have a patient with chronic kidney disease and then anemia secondary to the chronic kidney disease, and chronic kidney disease is likely because of diabetes or hypertension, just because you find an M spike when you check an SPEP, that doesn't mean they have active myeloma. They could just have MGUS or have smoldering myeloma and then have end organ damage secondary to one of these other medical issues. So again, memorize that progression: MGUS, smoldering myeloma, multiple myeloma. Be aware of the risk calculator for MGUS. Make sure you commit the diagnostic criteria to memory, because that's likely what you'll be treated on or what you'll be tested on. So now moving a little bit to talk about treatment. Again, active myeloma at this point is the only thing that we treat. There are studies looking at treating high-risk smoldering myeloma or high-risk MGUS, but really active myeloma is the only thing that we would start people on chemotherapy for. You do not need to know these, but just so you're aware, there are now a lot of treatments for multiple myeloma. So when I started medical school in 2010, the therapies were a lot more limited. But you can see since 2010, there's been kind of an explosion of different treatments. And so all these drugs that I've put in red, these are now all of the new treatment options that have been approved since 2010. So you don't need to know these. I think this is a little bit like, when you're tested on HIV, you don't need to know which drugs you treat HIV with. You just need to know that people should or shouldn't be started on antiretroviral therapy. So I think myeloma would be the same. You don't need to know these drugs, just know when to treat people or not treat them. And then this slide is just kind of on there for your reference and to know the different classes that we have. So there's chemotherapy, which we actually use fairly infrequently. And then there's IMIDs, or immunomodulatory drugs, that are all based off of thalidomide. There's proteasome inhibitors that all end in IB-IB for inhibitor. There's a few monoclonal antibodies. Daratumumab is probably the one you might hear about most. It's a CD38 antibody. Then there's a few other drugs with different mechanisms. Again, don't need to know this, but just so you know a little bit of what we're talking about when we treat myeloma. Basically, we just come up with a recipe that combines usually one drug from a couple of these classes. So most commonly, we'll use one IMID and one proteasome inhibitor and one steroid. The most common one we use is lenalidomide, bortezomib, and dexamethasone. And based off of the brand names for that, we'll talk about RVD or VRD as the chemotherapy regimen. But there are multiple regimens we can use in the frontline setting as well as second and third line. All of this is in flux because daratumumab, that one that's a CD38 antibody, is now, it's a very good drug, so it's being moved into the frontline setting. And so kind of all of our old triplet regimens are now quadruplets, and the doublets are now triplets. And partly because of this, because we have so many treatments for myeloma now, there's kind of a question of whether we truly need to transplant people or not, whether we need to put them through an autologous stem cell transplant, or whether we should just treat them with all of the different chemos we have. At this point, though, probably most people who are young and fit will try to do an auto transplant. So again, the bottom line, I've kind of said this several times, you should really know the diagnostic criteria for myeloma and know what the CRAB symptoms are. I don't think you're going to need to know treatments. I think you're much more likely to have a test question that revolves around knowing how to diagnose myeloma versus smoldering myeloma versus MGUS, and knowing whether you should treat or not. I think if you need to know anything about treatments, you might need to know about treatment categories. And I don't think you would be asked about daratumumab, and isatuximab is another CD38 antibody. But you might hear more and more about daratumumab because it's probably the best drug we have for myeloma. And just kind of an aside on it, is it's a very common question for us on our in-training exams and our board exams probably, is that CD38 is expressed on red cells. And so daratumumab will also bind to red cells and make people look like they have a positive Coombs test, even though it doesn't cause hemolytic anemia. So our common board question is knowing that before starting someone on daratumumab, we should do a type-in screen so that we can find out what antigens are on their red cells before we give them daratumumab, which will just bind to all the red cells and kind of screw up a type-in screen. But again, that's more for your edification and probably less for you to do well on ITEs or board exams. So at this point, I'll give a quick pause if anybody has questions on myeloma that they want to text into the box, or if they want to say over the microphone. Then I'll spend just a couple of minutes talking about the other plasma cells. All right, well, I will move on then, but feel free to text anything into the box that you want. If you have questions, we can come back to it at the end. So let's talk a little bit about Waldenstrom's. I was always really confused about what Waldenstrom's macroglobulinemia, or WM for short, what Waldenstrom's really is. Because it was always discussed along with myeloma, but I knew it had to do with IgM. So I didn't know if Waldenstrom's was just what we called basically multiple myeloma when it makes IgM. The answer to that is no. Or is it, you know, a subtype of multiple myeloma, but it has different symptoms? And the answer to that is also no. Waldenstrom's is really its own thing. And kind of the key to understanding how it's different from multiple myeloma is that it's really from a different cell. Waldenstrom's macroglobulinemia isn't really caused by that most mature plasma cell. It's considered a lymphoplasmacytic lymphoma. So it's really a B cell that's kind of earlier than a plasma cell. And another key is, remember from the slide earlier, this one, remember as the cells mature, they tend to lose CD20 and pick up more CD38. So multiple myeloma is CD38 positive, but CD20 negative. And again, we have that antibody for CD38, daratumumab, that works really well in myeloma. Whereas Waldenstrom's, the cells that cause it are more kind of from this area. So they're still positive for CD20, and they often get treated with our CD20 antibody, which is rituximab. So it's from a different cell. So if you understand that, it's really not multiple myeloma or a type of myeloma. It's its own entity coming from a different type of cell. That being said, it does make immunoglobulin. It always will be IgM. And the symptoms it causes are typically from hyperviscosity, which is because the IgM is a tetramer. And so it takes up a lot of space in the blood vessels, and it's really sticky. So it is very viscous and causes symptoms of hyperviscosity. So kind of a classic finding is seeing retinal damage, seeing retinal hemorrhages, seeing sausaging of the blood vessels. It can also cause strokes and clots and bleeding. It can also cause B symptoms like you would see in a lymphoma, more so than in myeloma. The reason for that is because it is a lymphoma. It's lymphoplasmacytic lymphoma. It can sometimes cause cytopenias because sometimes it can infiltrate the bone marrow and crowd out the normal cells. But by and large, it's a lymphoma that you often will see in the lymph nodes. So again, this is just a table kind of to underscore myeloma and Waldenstrom's are different. Myeloma is a plasma cell, whereas Waldenstrom's is a lymphoplasmacytic cell that still has CD20. Multiple myeloma can make any immunoglobulin or light chain, whereas Waldenstrom's is always IgM. The symptoms of myeloma will classically be those crab symptoms, whereas with Waldenstrom's, it causes hyperviscosity. The treatment for them is going to be different. Waldenstrom's is named for a dead Swedish guy, whereas myeloma is not. And then at the genetic level, they have very different genetic mutations as well. Don't need to know those. But again, just underscoring, Waldenstrom's macroglobulinemia is a different disease from myeloma. Don't confuse the two. So now another one that is maybe worthy of honorable mention is Poems syndrome. I don't know that I've ever actually seen a case of Poems, but I think because it has a cool acronym, you might get tested on it, or might, hear about it, or you might, if nothing else, you might be able to whip it out for a differential diagnosis sometime to impress your attending. But Poems, again, is an acronym that each of the letters stands for something. So P is polyneuropathy, O is organomegaly, E is endocrinopathy, M is an M spike or monoclonal protein, and S is skin lesions. So you can see any or all of these things in Poems syndrome. Probably all of the symptoms, even though we don't maybe understand all of why these symptoms occur, probably all of them are caused by the clonal plasma cell and the antibody it makes. Just as a pearl, Poems syndrome, it can be any antibody, but most commonly it's IgA lambda. I think about 50% or more of cases of Poems are IgA lambda. And the treatment for it will be similar to multiple myeloma. The last thing I'll talk about is amyloid. So amyloid is probably a separate lecture in itself, so I'm definitely not doing amyloid justice. But just to talk about it a little bit, remember that amyloid or amyloidosis, there are multiple types of amyloid, and not all of them are due to plasma cells. So there's AA amyloid, that's secondary to deposition of basically an acute phase reactant. So you can see AA amyloid in a lot of autoimmune diseases like rheumatoid arthritis is kind of the classic one, basically from inflammation and from overproduction of this acute phase reactant. There's also such things as dialysis-related amyloid. There's insulin-related amyloid. I actually saw a patient at the VA not long ago who was sent to us for amyloidosis because he had a skin lesion that was biopsied and they saw amyloid. So they sent him to us. And it ended up that was just where he injected his insulin in his belly repeatedly. So he got insulin-related amyloid. Again, that's not a plasma cell problem. That's just secondary to the insulin. There's also inherited amyloid syndromes like ATTR or the transthyretin amyloid that's due to a mutation in the protein so that it basically turns into amyloid fibers and gets laid down where it's not supposed to. And then finally, AL amyloid, for the L, think of light chain, so amyloid light chain. That's the one that's actually due to overproduction of light chains from a clonal plasma cell. So again, AL amyloid, that's the one that's actually under our purview in hematology. It's due to light chains overproduced by a plasma cell. Those light chains can get deposited in just about any organ, the liver, heart, kidneys, blood vessels, tongue, fat pad, etc., and can damage any of those organs. In order to diagnose AL amyloid, you need to have evidence of amyloid deposition, but then also have evidence that somebody has a clonal plasma cell that's making the amyloid. Ultimately, if somebody has a very low level of plasma cells and you think maybe they just have, they have amyloid plus incidentally have MGUS, you can send amyloid typing. I think Mayo Clinic is the only one that runs it, but you can send amyloid typing and they can actually type the amyloid and figure out if it's AL or AA or insulin related. So again, just be aware there's multiple types of amyloid. Not all of them are my fault though. Not all of them are due to the plasma cells. And then just remember a couple pearls on amyloid. So that's the one that classically when you stain it with Congo red and put it under polarized light, it will cause apple green birefringence. There's also a couple unique physical exam, or not really unique, but maybe testable physical exam findings that patients can have periorbital purpura. They can also have macroglosia, which is also known as pie crust tongue, which is kind of gross but fun to say because they're, I have a picture of it, I think on the next slide. Yeah, so you can see their tongue actually gets the little ridges in it that sort of looks like a crust of a pie, so pie crust tongue. The other pictures is just the periorbital purpura and then the apple green birefringence. Yeah, I know. So the last thing, again, I don't think you would be tested on this. This is kind of higher level information, but something cool maybe you can keep in your back pocket is that amyloid can cause a bleeding diathesis. It can cause bleeding because it binds specifically factor 10 and pulls it out of the circulation. And so you can get prolongation of actually both the PT and the PTT. So it will prolong the PTT and the INR because it binds factor 10 and can cause bleeding. So anyway, I think that's all that I have in terms of my lecture. My last picture is just my adorable girls. So I guess the final take-home point is you guys can forget all of this, but I don't know, just go get married and have kids, and they're fun. They're a lot more interesting than plasma cell dyscrasias. So anyway, that's all I got. Sorry for running well over time, but are there any questions that you guys have or anything you'd like to bring up? All right. Well, cool. Best of luck to you guys. If you see me walking around the hallway or you have some questions you want to ask later, feel free to shoot me an email or get my number from somebody and send me a text, and be happy to help you guys out. Anyway, best of luck to you. Thanks for inviting me, Scott. Actually, thanks for inviting me, Gene, but thanks for taking over and helping me out, Scott. I appreciate it.